Hi everyone, my name is Abigail McSweeny and I'm a first year PhD student in Dr. Christopher Odell's Tissue Instructive Materials Laboratory here at Drexel. And today I'm going to be discussing my work on targeted therapeutics to modulate myeloid-derived innate immune cell phenotypes. And the idea that's guiding this work is we know that macrophages and monocytes are critical regulators of inflammation post-myocardial infarction. So initially, someone has a heart attack, which triggers activation of monocytes in distant organs. These inflammatory monocytes travel to the site of injury and develop into macrophages, which guide the tissue response by either acting in a pro-inflammatory M1-like phenotype or a pro-reparatory M2-like phenotype. And after the heart attack, the initial infarct will continue to expand. But if inflammation doesn't resolve appropriately, this leads to continued global remodeling of the left ventricle and subsequent heart failure. This heart failure contributes to one of every 9 deaths in the United States, with about 70% of those cases being caused by left ventricular remodeling. And current treatments aim to prevent left ventricular remodeling and heart failure, but they don't actually address the underlying issue, which is the hyperinflammatory milieu. And small molecules are a readily available and effective treatment of inflammatory diseases. However, there are some obstacles to their implementation, such as their poor solubility, poor biodistribution, rapid clearance, and systemic side effects such as GI issues or leaving patients immunocompromised. So while these are a promising option to attenuate damaging inflammation, more work is needed to be done on their delivery. So our approach is to develop a delivery system that leverages supramolecular interactions, specifically guest-host interactions, to enable the local delivery of small molecule immunotherapeutics. And what this does is it allows us to bias macrophages and monocytes toward pro-reparatory phenotypes. So a previous PhD student in our lab conducted primary and secondary screens of a variety of small molecule drugs to look for M1 inhibitors and M2 promoters that have anti-inflammatory effects. The drug that was identified as the best candidate was Celestrol, and so what my work has been doing is looking further at the cell-targeted effects of Celestrol, such as the surface marker expression in monocytes, looking to see if they upregulate non-classical surface markers such as serous CCR1 and downregulate classical surface markers such as CCR2, as well as looking at protein secretion in human PBMCs to see if we can downregulate markers of inflammation, and looking at transwell migration in the presence of celestrol to see what changes occur in the crosstalk between macrophages at the site of injury and monocytes in distant reservoirs. So our primary outcomes is we saw that celestrol is a potent M1-like gene inhibitor and potent M2-like gene promoter. Celestrol is also able to modulate the expression of non-classical and classical surface markers. So we saw that when treated with zero point 0.1 micromolar celestrol, we downregulated CCR2 and uprated CX3CR1 in monocytes. Additionally, when celestrol was used on PBMCs, we saw that there was a suppression of secretion of pro-inflammatory cytokines, chemokines, and other proteins, and that celestrol is able to suppress monocyte migration towards bone marrow-derived macrophages that were treated with celestrol, indicating that we are inducing non-classical trafficking of monocytes. So from this, we've concluded that celestrol is able to alter the gene expression profile of macrophages. It directs monocytes towards a non-classical phenotype. It attenuates inflammation by modulating protein expression, and it modulates macrophage chemokine expression, leading to changes in monocyte migration. And with that, I would like to thank my advisor and my lab mates for their help on this work, my funding sources, and that concludes my presentation. Thank you.